Thank you for joining us and welcome to the Dignity Health Doc Talk on Stroke, a case review on emergency and preventative treatment, which includes an inspirational patient testimonial by Cheryl Freeborn, a stroke survivor and shared patient of our speakers. Before we get started, I wanted to share an upcoming educational opportunity with you. Urologist Dr. Youngstrom will be presenting on men's urinary health on June 9th. If you are interested, please RSVP at thedignityhealth.org /Bakersfield/Doc Talk. Now, let me introduce our speakers. Today we have with us Dr. Karan Thomas. Dr. Thomas graduated from Tufts University in Boston, where he achieved his board certification in neurology. He then completed his interventional neuroradiology fellowship at the Leahy Medical Center in Burlington, Massachusetts. He has lived in Bakersfield with his wife and children since 2013. We also have with us Dr. Sarah Hanari. Dr. Hanari completed her undergraduate education at USC. She then graduated with high honors from the Ross University School of Medicine. Her education continued at Conemaugh Memorial Medical Center, where she was awarded Best Intern of the Year during her surgery internship. After completing her surgical residency, she continued to her vascular surgery fellowship program at Bimades Medical Center in Brooklyn. Upon completion, Dr. Honari made the decision to relocate to Bakersfield, California, and join the team at Kern Vascular Center, helping to meet the needs of our local community. So with that, I will turn it over to our speakers.
Good afternoon. Thanks, Sean, for the introduction. I'm Dr. Karan Thomas again. I'm the interventional neuroradiologist and stroke and interventional service director at Bakersfield Memorial Hospital. It's a pleasure to be here today, and thanks everyone who has joined in. I'll tell you, this is the first time I'm doing something in this format on this medium, but hopefully it will not be any different from a real life meeting. Today, or May is Stroke Month. I don't know if it's appropriate to say Happy Stroke Month, but at least today it's a happy occasion because we have one of our stroke survivors, Mrs. Cheryl Freeborn, in attendance and joining us today. So it's a particular pleasure to have one of our patients who has done well. And thanks for agreeing to do this, Ms. Freeborn, and welcome.
Sure.
So being the Stroke Month, it is appropriate to discuss stroke, the mechanism of stroke, how does it happen, who are at risk for having a stroke, and what can we do to prevent one or to treat one when you have one. The treatment of stroke is actually a continuum. It is not a one-time event. It does not stop even after the initial treatment of stroke. It goes on for years after that. It starts maybe in the many years before the actual event itself, because stroke, the syndrome of stroke, which is characterized by dysfunction of brain and manifesting as symptoms in corresponding to the region of the brain that's involved. That event is usually many years in the making. It is a culmination of so many things that happens over many years, sometimes decades, that ultimately results in the stroke syndrome. And for that reason, treatment of stroke does not begin that day. It should have begun appropriately in appropriate cases, many years before the event itself. And there are exceptions to it. Sometimes you can have trauma and accident where you injure your carotid artery and then you have a stroke ensuing probably within minutes or hours or within even days of that event. That is an exception, but most of the time, strokes happen because of long-standing risk factors that add on and cumulatively end up in a stroke one moment. Today we have Mrs. Freeborn, who presented to us almost a year ago or so with stroke symptoms, and we'll just go over her case history to see what happened and how we treated this. There are two highlights to this case review. One is the fact that Ms. Freeborn is here today, healthy enough to speak to us about what happened. And the second is the programmatic approach to the care. So as I mentioned, I'm an interventional neuroradiologist. That means I study and take care of the blood vessels that go to the brain and the spinal cord. I'm not usually present in the hospital 24/7, but I'm available within minutes of being called. But many a time there is the strokes that present to the emergency room or that we encounter in real life, there is very little that I personally can do from my specialty perspective. So most of the patients are treated medically and they don't need, fortunately or so, they don't need our expertise. So the treatment of stroke, when it happens, starts from the time that the symptoms are recognized. And at this point, I'll ask Cheryl, can you recall what happened that day? Just, how did you end up getting to the hospital emergency room? Who recognized this first? And, what did you do about it?
Well, I'm thinking back now on September the 7th, you have the 8th on there. I was involved in a family project going in and out in the heat and packing and walking. And I was having little things going on. I felt something on the left side, especially when I turned to the left. I would feel things. I'm going to call that like a headache, which it was going on. But I went home that night. I slept. I didn't have a problem until the morning of the 8th. I was walking and spilling coffee because my right hand was not doing what it was supposed to do. And I ended up slipping in the floor. My daughter, who is a nurse, she came over and she looked me over and she said, "Mom, you may have had a stroke. You need to go to the hospital." And I said, "No, there's nothing wrong with me." And then that went on for a couple of hours. And then finally about 12, she called an ambulance. And that's how we chose Memorial. And we ended up there at Memorial. And I'm so glad I made that choice. But that's kind of what was going on until I reached that hospital.
So, thanks for recalling those that day. Now, the key thing here is that many a time you would tend to, or you would probably lean towards ignoring the symptoms of a stroke. The reason behind that, the reason for that is stroke is usually painless. Pain is one of the most motivating symptoms or factors that will drive people to the emergency room or to seek medical attention immediately. On the other hand, stroke most of the time is painless. No matter how devastating, how significant the symptoms are, people will try to wish that away, saying that, again, maybe I'm stressed, I'm tired, things will get better on its own, but that's not the case. So when you have symptoms suggestive of a focal brain dysfunction, because there's nothing in the world that can cause weakness of one side of the body for you to have trouble finding words all of a sudden, or to understand, trouble with your vision. There's very little that can produce these symptoms other than a stroke. So when you have those symptoms, the next thing to do is call 911 and get to the emergency room, the appropriate emergency room right away. And so the EMS has a huge part to play here. Recognition of the symptoms by the patient himself or herself, or the bystanders, including family members. And then EMS gets there, even if the patient or bystanders have missed that vital clue toward that point towards a stroke, the EMS most of the time are able to pick up, hey, this is what's probably going on, and we should get the patient to the appropriate center. So that is a rate limiting step right there. We know that the longer you wait, the more brain cells are being injured. We also know that brain cells, once injured, they do not regenerate. You can have rehabilitation. That means you may regain the lost function because there are redundant pathways in the brain that will help you do that, just like a kid would learn new things every moment of his life. But the cells itself that has been injured, they don't come back. So the sooner you get treatment to reverse the process or to stop the process, the better off you are in saving the amount of brain injury. So Cheryl comes to the emergency room via EMS, and once she gets there, it is a team of dedicated and specialist doctors, the ER physicians, who then evaluate her quickly because it is billed as a stroke, and that means drop everything, stop doing everything, and pay attention to this particular case. Once that is done, we have telemedicine or telestroke experts because, as I said, the treatment of stroke, the hyperacute treatment of stroke is in the order of minutes or sometimes hours. So we may not have the luxury of waiting for a neurologist to arrive. Most of the time, these neurologists are not in-house, they're in their offices. We don't have the luxury of making that happen many a time. So we have telestroke who can beam in on a patient within minutes of being alerted, assess the patient, and make appropriate decisions. And what would be the appropriate decision? Well, if the patient fits the criteria for treatment by a thrombolytic agent, thrombolytic means clot dissolving or clot busting medication. At this point, we have one FDA-approved agent called Alteplase. And if the patient meets the criteria for that, and normally the criteria is that you should suspect an ischemic cerebrovascular event or a stroke. 2, there should not be any hemorrhage inside the brain or a history of hemorrhage. And 3, they should be in the appropriate time window for treatment for that. So right now, what we have taken as a standard is either 3 hours for most patients, and sometimes 4.5 hours for a select group of patients for eligibility for treatment with this thrombolytic agent. So in Cheryl's case, unfortunately, she was determined not to be a candidate for intravenous thrombolytic therapy with Alteplase because of the time frame of events. She chose to wait a little bit before she finally ended up in the emergency room. And by then, she had crossed that 4.5 hour mark for treatment with this Alteplase. And that may or may not have had a deleterious effect on her. You know, it's very difficult to go and tell us, and find out if, you know, things would have been different if we treated her with Alteplase or not. But anyways, during the course of treatment, can you please go to the next slide? She had a CT angiogram of the head and neck, which again was recommended by the telestroke specialist and the ER doctors. And this was done quickly within minutes of arriving at the emergency room and within minutes of determining that she's not a candidate for the clot busting medicine. We got a CT angiogram, which is a CAT scan that's specialized towards assessing the blood vessels that go to the brain. And you can see on this picture that there's fairly good symmetry of the vessels up to the middle of the neck. And I don't know if you can see my cursor here, probably not, right? Are you seeing my screen, Sean? You're not, okay. So the cursor, you just have to imagine, is somewhere in the middle of the picture vertically. That's the middle of the neck. There's fairly good symmetry of the vessels up to that level. After that, where the vessels divide into two, one going to the face called the external carotid, and the other one going to the brain called the internal carotid, you don't see it on one side, the left side, which is to your right, okay? The picture to your right is the left side of the patient, and to your left is actually the right side of the patient. So the area in reference here, the region in reference here is the left side of the brain because of the symptoms that she presented with. And you can see that the left internal carotid artery is completely occluded right after the vessel bifurcates to form the internal and the external. And you don't see it at all the way up to the brain. And inside the brain, you can see fairly symmetric arborization or branching of the normal intracranial blood vessels. So the middle cerebral arteries and anterior cerebral arteries. I know it's difficult to make sense out of this without me pointing to it on the picture. Unfortunately, we cannot do it at this point. But regardless, the intracranial branching pattern looks fairly normal. So what we have is a patient with symptoms, and the symptoms appeared mild at that time or maybe even resolving, but she did have some degree of persistent symptoms. And you have a completely occluded left internal carotid artery in the neck, but somehow or the other, the intracranial, the vessels in the brain looked fairly normal. So then we were called asking, is there something we can do, we should do vis-a-vis opening up the vessel in the neck to make the picture better? So the key point here is in acute treatment of stroke, the idea is not to make the picture better, it is to make the patient better. So anytime you intervene, there's always a risk of causing further injury. So in a patient who looks reasonably good clinically and who has at least radiographic, meaning CAT scan related evidence of reasonably enough flow to both parts of the brain or all parts of the brain, we don't need to intervene. In fact, you should not intervene because you can cause more damage or more symptoms at that point. So let us go back to the previous slide quickly. So for that reason, the interventionalist who was called at that time said, we will defer interventional or revascularization because of a mild and stable neurological condition. Let's go to the next slide and the next one. So at that point, she also had a special type of CAT scan called a CT perfusion study. This is a study that tells us how well the tissue, the brain tissue itself, is bathed in blood. So normally, the brain needs oxygen and blood flow on a continuous basis. And anytime the blood flow is interrupted or compromised for more than a few minutes, 8 to 10 minutes or so, at least some parts of the brain will undergo ischemia or lack of blood flow related injury. And this one, the pictures on the perfusion study is a color-based map of how well, that tells us how well the hemispheres, the brain tissue is bathed in blood compared to the opposite side. So again, the side of the brain to your left is actually the patient's right, and to your right is actually the patient's left. So the left side of the brain, you can see that there is some asymmetry in the color distribution, and that's what that is telling us is, again, that hemisphere is not getting enough flow as much as the other side, the right side, and telling us, hey, you may want to consider intervention or trying to open up a vessel to improve that flow. So this was also taken into consideration, but it was decided not to intervene upon it because this perfusion study is not an absolute test, right? We have to take that in the right clinical context. And because the patient was doing well, the vessels inside the brain looked fairly symmetric compared to the right. We decided not to intervene on her because the risk of causing harm is greater than the benefit that you can derive from it. And unlike the rest of the body, the brain behaves a little differently in terms of blood flow and in terms of obstruction to blood flow. Brain needs blood and oxygen on a continuous basis. It's one of the areas of the body that there's most utilization of blood and oxygen. However, once it is occluded for a while, it may not like the floodgates being opened all of a sudden. It can turn into what's previously a dry stroke, meaning lack of blood flow. It can turn it into a bleeding kind of wet stroke, which may be even worse than the actual problem. So for all those reasons, we decided not to do anything and observe her very closely, which is what we did in the neurointensive care unit. So at that point, the patient is turned over to the care of the neurointensivist who will manage the medical side of things, trying to prevent further injury, trying to stabilize the pathological process that's going on, and maximize medical therapy, like keeping our blood pressure on the higher side, maybe adding a blood thinner or two. So those kind of things is what the neurointensivist does. And they are also geared in very close neurological monitoring so that they can pick up any changes in neurological function or status and inform the appropriate consultants, in this case, the neurointerventionalist, to consider or reconsider revascularization. So if we can go to the next slide, please. Next slide, please. Right. So a few hours after coming to the hospital, Cheryl started worsening clinically. Her weakness of the right side got much worse. She was not able to verbalize or answer questions as well as she was able to a few hours before. And so we got called in a second time saying that, hey, this is what's happening. Can you do something at this point? And we decided to take her to the angio suite because she was clearly worse than before. And what you're seeing is a selective angiogram. The catheter, the tube that you can see as a shadow is in the right carotid artery. That is not the side in reference here. The left side is what we are talking about. But before I went to the left side, I decided to study the right side to see how well the left side is getting, collateral flow from the right, if any. And what we can see on this picture, this is focused on the neck. We can see that there is at least a moderate or probably moderately severe narrowing right at the carotid bifurcation. You can see a very robust, juicy vessel coming up, and then dividing into two, right at the point of division, there is some junk there that's causing narrowing of the blood vessel. And the remainder of the carotid artery looks reasonably normal through its course through the neck. Next slide, please. For the same angiogram, for the same injection, this is an intracranial, meaning a brain view. The first one is head-on. The other one is taken again head-on, but taken a few seconds after the injection. And the first one shows that it is the right side of the brain vessels are filling symmetrically. There's irregularities there, meaning long-standing blood pressure-related changes or cholesterol-related plaques. It is filling reasonably well the right side. It is also on the second picture. You can see that it is also filling the left side to some extent. It is not going all the way to the big trunk called the middle cerebral artery, but it's collateralizing, meaning spilling over to some territory on the left side, which is already telling us that maybe the left side is not getting enough flow. So next slide, please. This is an injection of our vertebral artery, the artery that normally supplies the backside of the brain, but there are some connections. There's some redundancy to the blood flow, the structure or scheme inside the skull, where there are connecting pathways. This one I decided to study, see if any flow was getting to the left side of the brain via the posterior, via the back vessels. That wasn't the case. We don't see any opacification or any flow to the left side of the brain from this vessel either. So that tells us that the left side of the brain is pretty much on its own. It's not getting enough flow. It may be barely hanging in there with some collateral flow spilling over from right side, but much of the brain is at risk, if not completely infarcted, meaning injured. We don't know the extent of injury at that time. An MRI would have helped tell us, hey, how big is the stroke? Because she's already worse clinically. There's a chance that the brain is already injured beyond repair. But we chose not to do the MRI just in the interest of time. We took her to the angio suite, got these pictures that shows that the left side is compromised. And let's go to the next slide. And this is the left carotid. Again, just like the first set of pictures, my catheter is now in the left common carotid artery. You can see that it goes up, pretty robust vessel, and then suddenly narrows a little bit. There's a robust vessel and its branches coming off that's supplying the face and the scalp. But the vessel that should have gone to the brain, which you see as a little shadow after some irregularity there, is completely blocked. The left internal carotid artery is completely occluded right at the origin. Next slide, please. So in order to get to the brain, this concern was, okay, we knew that the left carotid was blocked, even a day ago, because she had a CAT scan that showed blockage of that vessel. We thought intracranially, inside the brain, everything was okay because of collateral flow, but now she has worsened. The question is, hey, does everything look the same as before, or has she flicked off another clot from this occluded vessel that is now occluding the intracranial, the vessels inside the brain itself? So to study that, the only way to do it is to try to open up the vessel that's completely occluded. And you can see that we go in with wires and devices and put a stent in where the previous occlusion was. I can see that now the neck part of the vessel, the neck part of the left internal carotid artery is completely open. Next slide, please. And this is the intracranial view. Once it is stented, we inject contrast. You can see that compared to the initial picture of the right side, the artery that goes and supplies the big chunk of brain on the side of the brain is now completely occluded, where it usually should have bifurcated, meaning divided into two or three branches. It's completely occluded there. So that is what was actually causing Cheryl's worsening, because the neck vessel was occluded for the last 24 hours or so. She did okay, but now something else flicked up from that occlusion and blocked the vessel inside the brain, which was previously not occluded, which was previously open. And that is what the real problem is, and that's what needs to be intervened upon. So next slide, please. So now we go in through that stental vessel. You can see the silhouette of a wire going into that vessel through the occlusive segment. And we, once we were in the position of the occluded segment, we deployed what we call a stent retriever. And you can barely see it on the second picture there because it's subtracted, meaning by some technique, we are able to subtract everything that's there, including the bone, so that the pictures will only show the passage of contrast. Let's go to the next slide, please. Same picture as last one, but unsubtracted. You can now see a device, these dots that belong to a stent retriever. So that stent retriever is now deployed or delivered within the occluded segment where we think there's a blood clot and unsheathed there. Next slide, please. So this is what a stent retriever looks like. It is like shaped like a stent. The only thing is we don't leave it. We don't deploy it just like we did for the carotid. In the carotid, we left a stent in there to keep the vessel open. This is a different device. Even though it's shaped like a stent, it is never deployed or left there. It is pulled out at the end of the procedure to suck out the clot or fish out the clot. And this is the schema of what it would look like inside the vessel. So if there's an occlusion, if there's a clot there, you go there and deploy the stent in that clot. And the idea is that the clot will slowly get trapped within the device, or the struts of the device will sink into the clot. And when you pull it out, when you pull the device out after, it will bring the clot along with it. Next slide, please. So we deployed the stent, left it for some time, and using suction and a combination of other techniques, we pulled it out. And this is after the deployment, after the angiogram at the end of the procedure. You can see that the left internal carotid artery goes up where it was previously occluded. It is now patent and open and supplying all the branches. There may be some tiny small branches which are occluded. It's possibly the territory, the regions of the brain that's already injured and infarcted, so it's not requiring blood flow anymore. But overall, the vessels look healthy and robust and filling the brain. Now, this doesn't tell us how much injury has already occurred, and that's a key thing in determining how well the patient will do over the next few months or years. And fortunately for Cheryl, it was not extensive injury, so she did recover remarkably well. So this is a story of Cheryl coming to the hospital, being evaluated and treated by an array of physicians that tried at stabilizing her with conservative measures first. And when that failed, we went to an interventional strategy where we went through her arteries and opened up a vessel that was previously occluded. Now, remember on the first set of picture, we studied the right carotid. The right carotid was also moderate to severely narrow, but that was asymptomatic, meaning that has not caused any problems. Remember, the left carotid also must have looked like that at some point in her life. If it was caught at that point, maybe we could have bypassed all these events that happened later on. So what do we do about that carotid? I'm going to let Dr. Hanari, who's our vascular surgeon and one of our greatest assets to our program, because as I said, the treatment of stroke is a programmatic approach. It is not a one physician or one specialty or one intervention. It is a continuum of care, making sure that patients are appropriately treated from the time that they present to long-term care in preventing further events like this. Dr. Honari.
Thank you, Dr. Thomas. So I'm Dr. Honari. I'm a vascular surgeon, as Dr. Thomas had mentioned, and I had the pleasure of meeting Ms. Freeborn in my office, not in an emergency situation, but the first time she came and saw me was in November 2020, approximately 2 months after her stroke. She had seen Dr. Thomas after she had been discharged, and he had repeated a CT scan in October. If we could go to the slide. Next slide, please. So the CT scan done in October, it was actually read by the radiologist as 50 to 69% stenosis, which we consider moderate stenosis. However, like Dr. Thomas had mentioned, when she was in the hospital, the angiogram was pretty significant for stenosis of the right side of the right carotid artery. So I performed an ultrasound in the office, and an ultrasound, we look at the speed of the blood flow going through this area of narrowing. And based on the amount of speed the blood flow is going, we can correlate that with a significant amount of stenosis. And it was actually noted to be greater than 70% stenosis on that. And so Mrs. Freeborn came back to the office after she had the ultrasound. She was accompanied by her daughter just a couple weeks later. And we had a discussion about it. Now, when she presented to the hospital, she had a stroke. She had an emergency situation. It was taken care of. In this situation, we were going to be preventing a stroke. And we talked about, the risks of her having another stroke on the right side based on what we had found, and the risks of undergoing surgery. And after significant discussions, we decided to proceed with an elective surgery at this point. You can go to the next slide, please. So again, I mentioned we had met each other in November 2020. Unfortunately, surgery was pushed back to February 2021 due to COVID restrictions and everything. It was deemed an elective surgery, and Ms. Freeborn and her daughter were very, understanding of that. But we finally were able to proceed with surgery, and Ms. Freeborn underwent a carotid endarterectomy, which basically consists of actually opening up the neck, opening up the blood vessel, cleaning out all that plaque and debris that can break off and cause the stroke, and then patching the artery up. So she did pretty well during surgery and afterwards, and she's followed up since, and she's done well. She's had an ultrasound to evaluate whether the blockage has returned or is worsening, and everything looks good at this point. She continues on medications, which will prevent hopefully the buildup of the plaque again. And she'll continue to have surveillance ultrasounds to evaluate that there's no scarring or buildup of plaque on both sides of the neck at this point. We can go to the next slide. So to talk a little bit about stroke and stroke prevention, risks of stroke, there's controllable risks that we can control, and there's risks that we don't really have control of, but at least we can be aware of them. Like in Mrs. Freeborn's case, the leading cause of stroke is actually high blood pressure, but it's also the most significantly controllable risk factor. Smoking is another cause, a controllable risk factor. The nicotine and carbon monoxide in cigarette smoke damages the cardiovascular system, not only in the blood vessels that are going to the brain, but the blood vessels that go to the heart, to the legs, to the intestines, to every blood vessel in our body. Diabetes is also an independent risk factor for stroke, but most people with diabetes also have high blood pressure, high cholesterol, and are overweight. So it increases their risk even more. Diet, physical inactivity, obesity, all these things can be controlled. Diets high in saturated fat, trans fat, and cholesterol raise our cholesterol levels, and that leads to a higher risk of stroke. In addition, diet high in sodium can cause our blood pressure to be increased. So like I mentioned, high cholesterol, the amount of cholesterol in the blood can build up, and this is what causes most of the plaque, and that's the plaque that can break off and cause the stroke. And so the risk factors that aren't in our control, age, with increased age, the risk of stroke does go up. However, stroke can be found in any age group. Family history is significant. If you have a significant family history, especially for anyone who's had a stroke before the age of 65 in your family, the risk of your risk factor for stroke goes up. In addition, race, African Americans are at a higher risk than Caucasians. And gender, women are actually at a higher risk for stroke, and stroke kills more women per men per year. So that's another factor that we want to keep in mind. And then also, if you've had a prior stroke or even a mini stroke where you've had symptoms but they return, or you've had any heart attacks or cardiac disease. So people who have had prior strokes are almost 10 times more likely to have a stroke again in the future. And you go to the next slide, please. So it's actually not recommended to screen the general population. So for asymptomatic people who never had any kind of neurological issues, it's not at this time recommended for us to go and do ultrasounds of the neck. However, patients who've had previous history of stroke, mini strokes, or any kind of neurological symptoms should undergo imaging and surveillance. And at this point, the initial imaging is with an ultrasound, which basically you have a probe placed on your neck, and we can look at the vessel and look at the speed of blood through the vessel and look at the plaque that's actually there. Next slide, please. And so at this point, the treatment options for patients who have no neurological symptoms and have about moderate stenosis, there are medical management options that we continue with, control the cholesterol, antiplatelet medications such as aspirin. And then we want to manage the high blood pressure and the diabetes and lifestyle modifications such as exercise, no smoking, things like that. And then for patients who have severe stenosis, even without symptoms, it is actually recommended to proceed with surgery. And for obviously patients who are symptomatic, it is recommended to proceed with surgery. And the surgery is usually the open surgery like we did on Mrs. Freeborn, which it's called a carotid endarterectomy, in which we go into the vessel and actually clean it out. And in some rare instances, carotid stenting is also indicated. At this point, I'll pass it on to Mrs. Freeborn for her to give us some of her insight onto all of this.
Oh boy, after all of that, I don't know if I have much to say. I would like to say the follow-up things that I feel have been extremely helpful is my physical therapy. When I left Memorial, which was 1 week, I ended up in in Compass, and I did 2 weeks there. Then I did a month at home, and I am still involved with the physical therapy group that I started after that. Extremely helpful. I had a lot of problems with the right side, and I had one health official tell me that my shoulder was like it was frozen. So I had a hard time getting this arm going. So I've worked myself through all of that, my therapy. And then I've also, I think there is a slide that will come up that shows that there is a site online that helps stroke patients. It's called Flint Rehab, and it is excellent for diet, exercise, and encouragement. Because until I went to this site, I wondered, I was thinking my death was imminent. And so it gave me hope, because there was a woman on there that they quoted had been a stroke survivor for 11 years. And she started the physical therapy again and was able to get back some of her ability. I don't know how much, but it was extremely encouraging. And I would love for this to be encouraging to other people, because it is possible. So that and diet, I had family support, a great deal of it, and it really helped me. All of these things are so important. And I trusted both of the doctors. I trusted what they said. I believed them. They took care of all of my concerns for each treatment that I had to, intervention that I had to go through. And I appreciate that so much. They both reassured me and let me know that it was going to turn out fine. And that was a huge encouragement for me. I think that's enough that I can say for the moment.
Cheryl, do you remember what symptoms you had? I know you did describe how it started, but when you got to the hospital emergency room, do you remember what symptoms you had? Can you list them?
When I arrived at the hospital, I think I was basically focusing on the right side. I call it my paralysis side. I know there's another term for it, but yeah, I wasn't able to stand. Balance. I'm sorry?
Could you move your arm or leg on the right side?
If I did, it was slight. It wasn't much.
Were you able to talk? Were you able to speak and understand?
I'm sorry?
Were you able to speak and understand? Was there anything wrong with your speech or language?
You know, I was able to speak, but I could tell in the back of my throat that something was not the same, and I had trouble swallowing. And my part in speech was recalling the word to my mind. I knew what I wanted to say, but it wasn't coming. And like a word that had a S or a C sound in it, that's all I could hear. I couldn't see as far, let's say it was listen, I would come up with some other type of word that, you know, I couldn't get spelling right. That's what I'm trying to tell you. So that's where my speech was affected.
I saw you only after your symptoms worsened, after a few hours after getting to the hospital. So I didn't get a chance to see you during the better part of your hospitalization or the initial phase. And I was told that it was pretty reassuring because you were able to talk well. And in fact, it was one of your daughters who picked up your worsening the very first time, because she said on the phone, you did not sound right. You could not speak as freely and well as you did a few hours prior to that.
It was weak. Yeah, it was weak. Yes.
So when I saw you, you could barely mouth any words. You could not verbalize. And two, you were completely paralyzed. You were weak, densely on the right side. And to be honest, I did not expect you to make this good a recovery. You're very fortunate, and many people don't get that chance, especially when the treatment is not, or the revascularization, opening up the vessel is not prompt, and things linger on. In your case, for the right reason, because we were not really sure. It was a 50-50 chance that because there are some patients who with an occluded carotid, they will do reasonably well without any intervention. So we were hoping that you would fall into that category, but unfortunately you did not. So to be honest, I was pretty concerned even after opening up the vessel and everything was done. I was concerned that your recovery would not be as good as it has been. So I'm particularly happy for you that you have.
Thank you very much. I appreciate that.
And it may sound that it was fairly routine and predictable, but no, your recovery, I'm pretty sure, even though I was not involved in the rehabilitation phase of your treatment, I'm pretty sure it was a long road to get where you are today.
Okay, thank you. I appreciate all that you did. I really do. And Dr. Hanari as well.
Thank you for sharing that, Cheryl. We do have a few questions from the chat, if you don't mind, for providers. Dr. Thomas, this question was directed to you. How long does it take to recover from a stroke?
Recovery is usually what I tell patients is in the order of weeks or months. So there are anecdotal cases, both in our experience as well as that's what's reported in literature. There are anecdotal cases where the patients, they come in paralyzed and right after the procedure, they walk out of the hospital the same day or the next. But most of the time, people are not so fortunate. There's always some degree of injury that's already happened before we can open up the vessel. And that injury always has a consequence, depending on where it is and the extent of it. There's always a consequence, a price to pay. So stroke recovery, the biggest factor that determines recovery after stroke is the amount of residual function, residual brain, preserved brain, as opposed to the injured brain. So the more residual or functional brain you have, the higher chance of making reasonable or good recovery. The more extensive the injury is, the longer it will take and less complete the recovery might be. So the bottom line is it's in the order of weeks to months, unless it was a fortunate case where people get away without any major injury. They can make a prompt recovery, but usually in the order of weeks to months. What you're doing is rehabilitating the brain, trying to get the brain, the residual, the functional brain to take over the function of what's lost. And that's just like, children learning new things from infancy to toddler and so on. That is the timeline of rehabilitation after a stroke.
Thank you for that. And Cheryl, I just wanted to make a comment. You've got so many thank yous and well wishes in the chat. I know they're addressed to everyone, but just wanted to make sure you're seeing these. In particular, someone said, Ms. Freeborn, thank you for allowing your experience to be shared. This content is very informative and helps us to better understand what happens during this type of stroke. It's wonderful to see you doing so well.
Well, thank you very much for having me. I'm glad that I participated.
And we also have another question. Why are stroke survivors so tired after their stroke?
Again, I think that's a question directed to me. So again, not everybody. It depends again on the extent of injury. And there are particularly some areas of the brain which are more prone to causing these constitutional symptoms such as fatigue. It is not actually a body or a muscular fatigue. It's more of a mental fatigue. You are working the brain, or whatever is left of the brain, to double or triple the function to make up for what's lost. So you can have headaches, you can have depression to add on to this, because just the thought of having had a stroke it can bear people down to a great degree. So it is a mental fatigue and emotional fatigue more than a muscular or body fatigue. And it is related to the amount of injury that you have. And also it varies from person to person.
Okay, and Cheryl, another question for you. Participant asks, if you could tell people any valuable lesson or lessons you have pulled from your experience, what would it be?
Well, I can tell you that I started out early trying to seek out a high cardiac calcium score, and that was several years before the stroke. And I wish maybe I had went down a different path. I'm going to say probably the most important thing is to listen to your medical advisor, your doctor, and follow up with everything, and just stay focused on that particular problem, and keep going. I'm sure that if I had not had these interventions, I probably would not be alive today. And I'm so thankful for it. So I appreciate Dr. Hanari and Dr. Thomas so much for what they do.
Wonderful. So, and Dr. Honari, we have one for you.
Yes.
Is there a group of patients that you wish would be referred to you sooner or more often? Are there opportunities that you feel are out there to prevent strokes from the vascular intervention standpoint?
So like I mentioned earlier, the buildup of plaque isn't just in the blood vessels that are going to the brain. So patients who've had heart attacks are at higher risk for stroke, are at higher risk for peripheral arterial disease. So patients who've had any kind of cardiac event should be seeing a vascular surgeon, should be evaluated for any of these. Also, like I mentioned before, sometimes these mini strokes that we call them, or TIAs, where patient's hand will go numb or they lose strength for a few hours, they don't think anything of it, and then they move on, and then they present with a larger stroke. You ask them, hey, have you ever experienced this? And, yes, I have. I think if we evaluate patients through primary care physicians a little bit better, if they have had symptoms of TIAs, to be sent to a vascular surgeon or to have the carotid ultrasound performed and make sure that there isn't any kind of high-grade stenosis or blockages causing these kind of small little mini strokes.
Okay, thank you for that. Another question for either provider. If I have a family history of vascular disease, grandparents, stroke, mother and father vascular disease, are there any preventative screenings I should do?
Not in particular. So by family history of stroke, we are talking, or we are referring to patients who have had first degree relatives who suffered an ischemic stroke before the age of 55 or 65 respectively, for men and women. But there is, as Dr. Honari alluded to earlier, these are non-modifiable risk factors. So whoever it is, whether you have a positive family history or not, the key thing to do is do what you can do, which is modify the risk factors which are modifiable. So that you can't do anything about the age, you can't do anything about your relatives who have the stroke, but you certainly can quit smoking. You can certainly have a good control of your blood pressure and your cholesterol and your diabetes if you have any. So more than doing an ultrasound to see if there's plaque buildup in the carotid, because according to the data that we have, there's not much of a role for screening for this particular instance. But if you control your blood pressure, it probably would go a much longer way in preventing a stroke. For instance, there was a study that came out many years ago, more than a decade ago, that a 10-point reduction in your systolic blood pressure will lead to a 50% reduction in ischemic stroke. So that is how important blood pressure control is in prevention of stroke. The other thing is, once you have symptoms, again, not to ignore them. And so recognition of symptoms is key, and seeking the appropriate specialist opinion or intervention as indicated. So to answer, coming back to your question, a family member who has a stroke, first of all, find out if it's really relevant, meaning everyone will get a stroke if they live long enough. Because it's blood vessels, they're bound to deteriorate with age and time. And but if you have had a family member who had an early stroke before the age in his 50s or early 60s, then it may be reasonable to consider yourself at a higher risk for stroke and be more aggressive in primary risk factor reduction. Other than that, there's no real role for more screening or interventions.
Okay, thank you very much. I don't see any additional questions. So I just want to again thank our specialists and our guest speaker for providing the valuable content and the great questions that we received from all of us at Dignity Health and the providers organizations. Thank you so much for joining us today. If you have further questions, please reach out to the Bakersfield Memorial Hospital Neuroscience Institute or Kern Vascular at the numbers shown here on your screen. That concludes our event today. And thank you again for your time and have a great afternoon.
Also, thanks.